Hey, Matthew. Yeah, all yours.
Thank you. Good morning. All right, so we're going to discuss urinary sediment microscopy for kidney disease diagnosis this morning. So my disclosures, nothing pertinent to this talk today. Okay, starting with this seminal paper. I love old manuscript. This is 1925. Thomas Addis reported this paper titled Renal Failure Casts. It's a report of 63 patients that had been evaluated for kidney failure in a hospital. And he noticed by conducting urine microscopy at that time, the presence of this sort of broad, wide casts. They were different than other more thinner casts. And they looked at 37 of those patients with the broad casts and noticed that the blood urea level was much higher at 144 milligrams per deciliter compared to the patients with thinner casts. And that's why he decided to use the term renal failure cast. He also has some tissue diagnosis that, believe it or not, is one of the few pieces of data in the entire medical literature where you have a correlation between urine sediment and tissue, where you have those casts of waxy appearance, including the ducts of Bellini, and the beginning of understanding that this is the waxy cast form deep in tissue when the tubules approach the collecting system. So this is what we learned back in 1925, and that paper is still current, and I would invite the fellows to read it. It's really phenomenal how ahead of his time Thomas Addis was when this document and his JAMA paper. Now let's fast forward what we understand today. We're going to be talking about casts for the most part in this presentation, and just to remind you quickly how the medullary thick ascending loop of Henle cells produce this protein called uromodulin, and that constitutes the matrix of casts. As you can see in that image on the left-hand side, a anti-uromodulin antibody was positive in this report by Orita in Japan, 1977, early observations. Later on, we learned from Karl Gottschalk how acidic pH is associated with more formation of casts. Then we learned from the work from Bob Schreier's lab in Colorado how some proteins can form polymers, and once the polymers are formed, that's where the matrix of the cast starts and is favored by a urinary solution that contains sodium and urea. And if you have a tubular or interstitial insult, those sort of a cell debris or proteins are going to get into the cast and form granular casts or renal tube epithelial cell casts. If you have a glomerular insult where you have some RBCs going across, you may have an RBC cast, a lipid cast, or even a white blood cell cast. And if you have anything, ultimately could progress into a waxy cast. So we'll be talking about some of these casts and what is the clinical evidence we have today of their clinical utility. So starting with the granular casts, which is definitely the one that we encounter most often in clinical practice. And Mark Perazella in 2008 provided this seminal contribution that sort of revived the value of microscopy in clinical practice and provided the first sort of formal quantification of its diagnostic utility. So important work by Mark. And essentially his group at Yale created a score based on the number of casts and renal tube epithelial cells and stratified them, and they were blinded to the clinical history and then went back and reviewed the charts after the fact to determine who had renal ischemia, who had ATN. And the bottom line is that in patients that have a high pretest probability of ATN, and a score greater than 2 had a positive predictive value of 100%. And both patients with low predictive probability, an ATN score of 1 had a 91% negative predictive value. So very good to confirm a clinical suspicion, as you can see. And then shortly after, Mark also looked at the prognostic value. What about prognosis? Can we predict who's going to do worse? And similarly, this time the cohort was 197 patients, similar baseline characteristics in terms of AKI or oliguria. Using the same score, they found that the risk for worsening AKI, which is moving from stage 2 to 3 or requiring dialysis, was higher with a more abundant CAS. Now, on that box here of RRT, it's important to note that although finding more CAS in the urine had a greater risk of RRT, only a quarter of the patients who had scores of 3 require dialysis. So it's not to say that if you see abundant amount of CAS, that is not necessarily telling you, oh, the risk is like 80%, nothing like that. It's just way higher than if you don't have them. Okay, so what I'm going to be sharing with you today is some of the observations that we've had. We've used urinary microscopy in our clinical practice, and we have taken some of the observations and try to go back and do some formal analysis to see if we can have additional contributions in this field. So first observation that we published, it was actually hosted by the NFJC Journal Club a few years ago, is that we had the bedside observation that we often repeat microscopy when the first inspection and day one is not satisfactory. We go 2 days later and we look at the urine again. We're just not happy or not clear what's going on with the patient. The question is, are we wasting our time, or is there any value of looking at the urine for the second or third time? So for this and all the studies that I'm going to share with you today at Oxford Medical Center, we have established a prospective observational cohort where every patient that is seen in the consultation service in the hospital or in clinic, that the clinical team decides to conduct microscopy, we collect that patient data, clinical data, urinary microscopy. Okay, so this is, we don't randomize patients to this. Everybody, this is standard. This is sort of a standard of care, and the causes of assessment or consultation are AKI for the most part, because in some cases was progressive CKD, proteinuria, and hematuria. So everybody had microscopy. As I said, those patients go into the cohort, and we have a system to have image acquisition and storage in a virtual platform, so we can go back and analyze it. And our team is sort of trained how to store the images, so it's a consistent pattern that we have. And then, well, obviously, we extract clinical data collection. So this is the platform that we use for the studies that I'm going to be sharing with you today. So the first contribution that we published in Kidney 360 in 2021 was a study led by Vipin Varghese, a former resident auctioneer. 121 patients went into the study. Essentially, we had planned to conduct a second and a third microscopy throughout the hospital stay. As you can see, the number of patients who had a second microscopy was 105 compared to 121, because sometimes patients got discharged or had some sort of outcome that precluded doing a second or a third microscopy, and 49 patients had even a third inspection. So what were the results? Here is that using the Parcella CAS score, we were able to find evidence of acute tubular injury on a first microscopy in 42% of these patients. Now, you may think that's high, but remember, these are patients that have already been managed by the hospital medicine team. Renal ischemia has been ruled out for the most part. Patients who don't respond to fluids, then we get consulted. So we are obviously enriched on ATN. And then 11% of the cases, evidence of ATI was only found upon second microscopy. And even further, 3% of patients had bland sediment twice, and only on the third inspection we found evidence of microscopy. And of course, 45% of remaining never had evidence of ATI throughout the study period. So in summary, 23% of the patients converted from a non-ATI to an ATI sediment. And the question was, well, how often does that happen? In what cases should I suspect? Should we just repeat on everybody? Obviously, that wouldn't be feasible. And we conducted a regression analysis. What we observed is that the risk for conversion from non-ATI to ATI was in those who had an AKI that was not recovering. It means the creatinine was going up or not getting better, those were the patients that were more likely to find CAS. And it makes sense, right? If patients are not getting better, you're still suspecting ATN, it's good to be reassured of the diagnosis. All right. The second observation that resulted in a recent publication also was that we had been encountering cases in which there was a discrepancy between the fractional excretion of urinary sodium less than 1% and the presence of muddy brown granular CAS. We learned from Bob Streyer's seminal paper that if it's less than 1, it should be prerenal, and we were seeing urine sediments like the one in this image that didn't look like a prerenal sediment. So the question was, how often does this discrepancy occur? Is this just a weird anecdotal cases that are not common? And then which parameters should be more associated with actual ATN on a biopsy? That was also the questions we wanted to test. Okay, so following the same platform, in this case, 270 patients went into our analysis, and everybody had not only microscopy, but also FINA was required. And again, we took patients that FINA was ordered by the clinical team. We didn't order it, so obviously there was a loss of patients for that reason. And starting with the percentage of patients who had abundant muddy brown granular CAS in the urinary sediment, it was 43%. And again, this is enriched in ATN because it's a consultation service, as you can see in that image on the bottom. And here are the numbers. So on the pie chart, you see the proportion of patients had a fractional excretion of sodium greater than 1 or less than 1%. So you can see that about a third of the patients had a FINA less than 1%. Even though they had abundant muddy brown granular CAS. And within that abundance, we look at those who were super abundant, like the image shown on the bottom of the slide, where greater than 50% of the low-powered fields had muddy brown CAS. And it was 36% of them had a FINA less than 1%. So clear discordance between the two. So when we performed kappa coefficient analysis, it was deemed as a fair. And then we look at those subgroup of patients that had AKI on CKD. And this is interesting because in previous reports or where FINA was listed as a good diagnostic test, you often read, okay, FINA is good, but you don't want to use it in rhabdo, or you don't want to use it in non-liguric patients or in GNs because it's less than 1. And you would also read that in pre-existing CKD may not work. And this is the first time that we are able to show that indeed it's true, that the kappa coefficient was even worse at minus 0.11. And then we also look at a cohort of 95 patients who had a fractional excretion of urea nitrogen, because sometimes urea nitrogen is claimed to be this, the savior that is going to fix all the FINA problems. It didn't. The correlation was also pretty poor at 0.09. Okay, so and then we decided to look at sort of a confirmatory evidence of ATN, and the only way we can do that is with a tissue diagnosis. So out of this cohort of 371 patients, 49 of them had undergone a kidney biopsy within 2 weeks of microscopy. I know obviously 2 weeks could be a very long time, but the majority of patients had a biopsy done within 5 days of the microscopy, but the range that we utilized to capture more patients was 2 weeks. So this was patient that had microscopy showing ATN, as this dark field image right here on the bottom, and they had ATN on tissue. So what were the results in terms of predictability of ATN? Well, the positive predictive value was 100%. Every single patient in which we found abundant muddy brown CAS in the sediment had ATN on the biopsy. The negative predictive value wasn't good, so it's important to note that it's not necessarily a good exclusionary test, but in terms of specificity and PPV, perform as good as you can be. And the fractional excretion of sodium greater than 1%, which could be considered an indication of ATN, did not perform as well. PPV was 91% and specificity was only 71%. So with this information, we concluded that you have to attention to be paid to microscopy in cases where the FINA may suggest renal azotemia. All right, next observation. I have presented yesterday a little bit of this when I talked about hepatorenal syndrome. And then this question was that the International Club of Ascites criteria does not include microscopy to distinguish ATN from HRS, and we wanted to see how often the sediment may change the diagnosis despite all the criteria being consistent with HRS. And this is following the study that Andrea Allegretti had done at Harvard, and I showed you yesterday in 22% of the cases, by looking at the urine, they were able to reclassify patients as ATN. And our study that included 234 patients, we are actually able to convert similarly in 23% of the patients. So we do that as a standard of care for our practice in patients with AKI and cirrhosis. The other interesting observation in patients with liver disease was that when they present with elevated serum bilirubin, we tend to see numerous renal tubular epithelial cell casts. And that was sort of an interesting observation. And we wanted to see how consistent it is and in relation to the bilirubin levels. Is there really a relationship or not? So for this study, originally reported in 2018, the most recent update of this cohort, now we have 600 patients went into this. Essentially, we compared the frequency of finding these casts in patients with cirrhosis in orange compared to AKIs without cirrhosis, 421 patients in black, and it's still pretty remarkable. This difference is very clear. You may wonder that, well, maybe the bilirubin pigment allows you to find them and not an ATN. That's probably not the case because we have performed a very careful examination using stains and ways that we can catch them, and we still see the difference between them. And it is also important to know that the higher the bilirubin, the higher the probability of finding these casts. The average bilirubin for this group was 26 milligrams per deciliter. We do get patients referred to Ochsner in acute and chronic liver failure or coming for liver transplantation. So we get to see bilirubins in double digits almost on a daily basis in our center. And what is important is that while this study may suggest that because you have renal tubular epithelial cell casts, this evidence of ATN may explain a lot of the AKIs and cirrhosis, we have to look at this study by Jose Antonio Poloni in Brazil, and he's a laboratory pathologist. 1,096 patients went into his analysis, and he also looked at the relationship between serum bilirubin and the abundance of the muddy brown granular cast going from normal to severe. You can see that the more the higher the bilirubin, the more the abundance of cast, the percentage up to 50%. But that happened whether you had AKI or not. So it wasn't really driving necessarily the drop in GFR. So at this point, we see the presence of this cast as perhaps presence of tubular insult, but maybe subclinical and may not be necessarily what is driving the AKI. So don't be surprised if you find those casts in high bilirubin. Okay, going back to the drawing board, the other observation that we had was that waxy casts are often found in the absence of pre-existing chronic kidney disease. Why was that important? Because some of you may be familiar with this handbook of routine urinalysis by System Lorraine Graf. You know, so it's sort of a traditional textbook of urine microscopy that has a paragraph where it says that waxy casts are associated with chronic renal failure. And you kind of read the same statement in different textbooks, and that's kind of the traditional teaching that is associated with chronic disease. But we have seen it in patients that didn't have CKD, and the question was, is it truly associated with CKD, or it could be in other forms of kidney disease? So for this study, was originally reported at Kidney Week in 2019, the most updated cohort in 2022. 167 patients went into this analysis here. And first of all, in terms of the frequency of finding waxy casts, 28% in this particular cohort. And here's the distribution of patients that had either de novo AKI, meaning no pre-existing CKD, was 70% of them, versus patients that had AKI on CKD, which was only 30%. So essentially, it wasn't really necessary to have evidence of CKD to find this cast. And you can see in AKI, as you can see in this image, this cast is sort of pigmented with hemoglobin, and this other cast here on the top are stained with a Sternheimer-Malvin stain. And we went further and tried to see whether this cast may be associated with the severity of the AKI, and here finding the combination of waxy cast and muddy brown granular cast increase the risk for renal replacement therapy within a hospital stay. And also the abundance of waxy cast was also correlated with the risk, as you can see here in this chi-square for trend. So waxy cast no longer are present in ATN and AKI, but maybe also an indication of severity. So not necessarily just chronic renal failure. Now, other interesting aspect of waxy cast is that when we see cast in the urine, like the one on the top left image, where half of the cast is granular and the other half is waxy, and here the bottom image, we immediately conclude that this is probably a transition stage where some casts were granular early on and became waxy, or vice versa, but it's some sort of conversion in that realm. But it's also important to recognize that occasionally you will see waxy casts with cellular elements like red blood cells in it, as you can see in these images here, where in this particular specimen, there were no granular casts whatsoever. All you see are either red blood cell casts, waxy casts, or waxy casts with RBCs. And here another example of the same phenomena. So when you are inspecting the urine and you see abundant waxy casts and you don't see granular casts, for us that's an indication, well, maybe this is a patient with potentially even acute glomerulonephritis. So it's important to have that knowledge so that you don't immediately assume that waxy casts are just signifying ATN. And then going back to this paper by Thomas Addis, remember I showed you the renal failure cast. There were this broad, wide cast. So we had worked with a team of undergrad students at the College of Charleston, part of a project called EuroCap. I'll share you a few slides a little bit in a few minutes. So one of the students embarked in a project to measuring these guys. We were wondering how big are these guys. It was just sort of a fundamental question that we didn't expect to have any clinical relevance, but we conducted measurements of this cast, granular waxy cast, you can see here. And what interestingly, the measurements have, there you go, sorry. The measurements of waxy cast, looking at the width of the cast, appears to have a correlation with the serum creatinine level. Again, this is a small sample size of 19 patients, but it makes us wonder that this observation of Addis that the broader casts were bad may have actually a way to be quantified systematically. And again, not to pretend that we're going to be measuring cast in real time, but digital scanners these days are very powerful, and they can actually provide an output with the measurements for ourselves, and maybe it could be a prognostic tool at some point. So it's interesting that we're going to continue working on this project with the undergrad team at College of Charleston. All right, so the next observation was this presence of crystals in the urine. And again, finding crystals in microscopy is one of the most challenging parts of this technique, because a lot of times we don't know what we're looking at, and we don't have a quick way to corroborate if a given crystal is a drug or something else. But we kept seeing these crystals that had this particular appearance of brownish, some spindle shape, or this shape, as you can see in this image, and in patients that had been exposed to ciprofloxacin. We had a couple times, and we started, okay, is this a pattern or is this a coincidence? So we wanted to kind of just capture all patients that we could see with these crystals. And this is an example of a case where the crystal, you can actually look at it and be confused with the muddy brown granular cast. And only when you put the polarized light, you realize that you're in front of a crystal. And this is another example here of of another cast where in the middle of the cast, you see this brownish material that you don't recognize until you put a polarized light, and it's really evident that there's some crystalline structure embedded in a cast. This is work by Dustin Chalmers, who was a medical student at that time in our team. So we presented this at Kidney Week in a poster session last year. We had 6 patients where there was a clear exposure time represented in the red boxes that preceded the microscopy and the presence of those crystals. We don't have biopsy-proven crystalline tubulopathy in these cases to be sort of the confirmatory association because most of the times we recognize the crystal, we stop the ciprofloxacin, and a few days later, the patient starts to get better. So academically, we would have wanted to biopsy these patients, but we didn't because there was no medical indication. So that has been the challenge to really confirm this. But we're pretty certain that these crystals represent ciprofloxacin crystals. And the only study that we found that has been demonstration of actual identification of the crystal by infrared microscopy came from this French author Montagnac, which he found these crystals in the kidney and showed that they're actually ciprofloxacin salts. And then the final image that I'd like to share, this is a report by Sedlasek and NDT 2006. Patient had AKI, found this crystal, called it ciprofloxacin, and the top image by bright field, the bottom image by polarized light. And this is a crystal that we have found in our laboratory, almost identical. So it's really reassuring when the findings are pretty consistent. So we're pretty certain that these crystals constitute ciprofloxacin medication. All right, we'll move on to the glomerular disease or parenchymal, more of interstitial injuries. Here is starting with the acanthocytes, this dysmorphic red blood cells characterized by RBCs with a hole in the middle and protrusions or blebs that give this morphology. We don't know what is the origin of those deformities, but you can see this image on the left, how an RBC traversed the GBM, and perhaps that leads to that, some of that morphology. And important that the bright field technique is not the most optimal to catch this acanthocytes. Phase contrast is by far the best, and dark field is also pretty good. But trying to find acanthocytes on bright field microscopy is not easy. It's a challenge, and I would not encourage you to do that. Phase contrast is definitely better. And this is the seminal report by Hans Kuller, 1991. He used, of course, phase contrast, very popular in European hospitals. In his cohort, he took 330 patients that had either a glomerular disease or a non-glomerular or urological disorder, including patients with nephrolithiasis or bladder tumors, and essentially try to show if these acanthocytes are specific for a glomerular condition. And it did. 52% of the patients that had glomerular disease had acanthocytes in the sediment, compared to 2% of those without glomerular disease. So very, very specific, as you can see in those numbers. So what had been our observation in our practice is that we thought that we're seeing this more often, and we were looking at patients that we had biopsy-proven GN. We had the observation that we thought that when our sensitivity was probably 75%. So we just wanted to test, kind of verify the observation by Kuller and see what our numbers would be, and to look at the positive predictive value, et cetera. So for this cohort, this was led by Akansh Ramanan, a future fellow, actually, who's moving to Northwestern. He was a resident with us, and our former fellow, Anna Stark. For this project, 17 patients, 117 with glomerulonephritis. Now, our control group did not include urological causes like bladder cancer our control was kidney disease, which was not a GN. And obviously, that's a little bit more stringent, more rigorous to have that comparison. And we still wanted to see how was our performance. And the bottom line is that sensitivity was 63%, a little bit higher than color, but not at 75% that we suspected. And you can see that the specificity was the best number of 85%. Now, why wasn't 100% if it is glomerulonephritis? Well, because we were very specific looking for glomerulonephritis, meaning proliferative GNs, IgA nephropathy, ANCA vasculitis, lupus nephritis, all those type of GN, nephritic GNs by definition. But if you include all glomerular diseases, including diabetic nephropathy, focal segmental glomerulosclerosis, and we just look at the performance of acanthocytes for glomerular disease, now the specificity and the PPV turned to 100%. So essentially, acanthocytes equal glomerular disease. Usually GN, but it may not be a GN. Contrary to some reports in the literature that claim that in diabetic nephropathy you should not see. We have actually biopsied about a handful of patients with diabetic CKD that we biopsied because the only thing we found was acanthocytes, suspecting that we were missing something else, and the biopsy showed good old diabetic nephropathy. One of those cases showed microaneurysms, which may be the pathological sort of explanation why you may see these acanthocytes in a diabetic kidney disease. And we also looked at the combination of acanthocytes and red blood cell casts. Red blood cell casts are sort of the elusive casts, not easy to catch. You have to pay extra attention using high magnification. Sometimes you may see them and think they are granular casts. So in that case, you can actually improve your specificity to 100% if you include RBC casts into the analysis. And interestingly, looking at crescentic GNs, 88% of the crescentic GNs had either acanthocytes or RBCs. And finally, the other interesting observation for us is that for some reason, lupus nephritis is not a condition where we tend to see a lot of acanthocytes, whereas in IgA, ANCA, and infection-related GNs is pretty common. It could be that in lupus, we catch a lot of patients at an early stage. You know, we are much more proactive about biopsy patients when they have a little bit of protein, a little bit of urine, but not necessarily an advanced rip-roaring RPGN, and that might be the explanation. But it's important to know that the acanthocytes are more often in the other type of GNs. All right, back to the drawing board here. What was the bedside observation is that we often find WBC cast in cases of biopsy-proven GN and rarely in cases of AIN. And here is a little snapshot of a tweet. We posed the question, what do trainees think about WBC CAS? And this doctor answered that AIN in nearly all board shelf exams I've been in medical school and residency. So much that if I see a WBC CAS in a UA, I select AIN if it's an answer choice. I don't have to read the question. Okay, and I think a lot of trainees would agree with this statement. They have taught us for years that WBC CAS equal AIN. And it's interesting, you read the Fogassi textbook of uromicroscopy, and he does mention that you may see it in crescentic GNs, and we have the same observation, so we wanted to really test this question. All right, so before I show you our data, we look at the literature, and it's interesting how some evidence of this discrepancy was already in the literature and not being caught. This is Giovanni Fogassi, first of all, 2005. He had this publication where he showed that RBC casts are the best indicators of proliferative glomerulonephritis compared to non-proliferative GN, essentially comparing a MPGN versus an FSGS, for instance, as an example. You can distinguish GNs using an RBC cast, but look at the percentage of WBC cast in patients with proliferative or non-proliferative GN was 11% and 4%. Okay, so there was some presence of WBC cast. Then we have this more recent study in 2021 from China. These investigators were trying to determine if findings in the sediment would allow them to distinguish IgA nephropathy from lupus nephritis. Well, the answer is no, you can't do that. It is not as specific. But the reason why I'm sharing this study is because when you look at the proportion of patients that had either WBC CAS or RBC CAS, it's actually pretty similar, but more importantly, they were able to find more WBC CAS than RBC CAS, and this were all glomerulonephritis. And then also Fogassi in 2012 submitted his research letter to the editor where he took 21 patients who had biopsy-proven interstitial nephritis and had performed microscopy prior to the biopsy. And you can see here the type of casts that they found, hyaline, granular, etc. But look at the center here, WBC CAS and RBC CAS. RBC CAS were more common in his study than WBC CAS, even though these patients had acute interstitial nephritis. So this, you already have, as you can see, some evidence that this may not be the best AIN marker. So we conducted our study for this. Dustin Chalmers was the leading investigator as well. 683 patients went into this analysis. Out of those 683, 103 had kidney biopsy diagnosis. So the first observation is that WBC CAS were found in 36% of the patients in this cohort. And again, you may think that that's a pretty high number, where these are patients that we ended up doing a kidney biopsy. So clearly the enrichment with GNs is there. You're going to be more likely to biopsy somebody where you're suspecting a glomerular disease compared to a tubular disease. And in 73% of those cases, the diagnosis was glomerulonephritis. And when we compare the performance of WBC CAS for the diagnosis of either GN or acute interstitial nephritis, you can see there that AIN was actually rare. 2 out of 11 patients had WBC CAS compared to 73%, 26% of those with GN. So I'm not the purpose of this data is not to show you that WBC CAS are phenomenal diagnostic tests for GN. It's just to show that they're just not good for AIN, and we should not be definitely not asking on the boards something that is so uncommon. White blood cells are very common, but not white blood cell CAS. Not sure why, but that's what we have observed. Okay, so think about GN when you see these casts. All right, and then moving on to one of the sort of the new kid on the block. You can see this cast here on the left-hand side has this unusual appearance of some vesicles of various sizes, kind of looking lipidic in aspect, and we didn't know what these guys were. And we wanted to see, is there any type of clinical phenotype that is associated with these casts? But the trouble is that when you are seeing something, you don't know what it is. What do? You try to check with your colleague. Have you seen this? What do you think it is? Nothing in textbooks about these casts. And there's one report in the literature. Because of the vascular aspect, we searched and we found this report by Carlos Martinez Figueroa, a laboratory pathologist from Mexico. And I was able to find him. I saw him on Twitter, ended up calling him. I talked to him about this case. And essentially, this is a patient, was a peritoneal dialysis patient that the urine was sent to the lab because the physician suspected a UTI and nothing to do with diagnosing AKI. And when he was reviewing the sediment for UTI, he found this cast and ended up reporting it as a vascular cast. The patient had a 4+ protein in the urine, but this is an end-stage renal disease patient. In his report, he only has 2 citations from a Japanese document that is not translated to English, so I haven't been able to get more details, but there was nothing else in the literature. So for that reason, we use our medical education platform, social media, we started sharing these pictures on Twitter, and we had some other colleagues around the different countries in the world who do microscopy and had similar observation. Yeah, we have seen these casts and have collected data. So we started gathering this data to try to see, is there any consistent pattern of the clinical phenotype? So we ended up collecting 46 patients that went into this cohort. We at Oxford contributed with about 32 of them, the most high number. And you can see on this baseline characteristics that serum creatines were elevated at a 3.1 milligram per deciliter average. 98% had significant proteinuria, at least 2+ per dipstick. And the urine protein creatinine ratio was actually measured in 39 out of the 46, and it was 6 grams. So this appeared to be patients with heavy proteinuria, advanced kidney disease for the most part, as you can see in that box here. And here is some additional image. We had a subset of 16 out of these 46 patients that had tissue diagnosis with a biopsy, and we'll look at the urine protein creatinine ratio of those patients compared to a cohort of patients who had kidney biopsy done during the same time period in which the urinary sediment did not show vacuolar cast. And it was a pretty clear difference in the degree of proteinuria, as you can see here. See how the images I'm showing you at oblique illumination. This is a bright field unstained image of a vacuolar cast. The image here is a dark field microscopy, and finally another one with the Sternheimer-Malvin stain. All right, and then the next interesting observation was the specific histopathology, and you can see in this table that this is not specific for any type of glomerular disease. You saw it in patients that had diabetic glomerulopathy, various podocytopathies, even thrombotic microangiopathy, and some degree of interstitial fibrosis and glomerular sclerosis, as you can see in those numbers. And when we look at the percentage of cases with greater than 30% glomerular obsolescence, that was more likely to occur in patients that had vacuolar cast. And when we look at cases with absolutely zero sclerosed glomeruli, that never happened in vacuolar cast, 0% compared to up to 20% in cases without vacuolar casts, as you can see in that image right there. And finally, we look at the biopsy reports and the frequency in which vacuolization of tubules or podocytes was mentioned in the report, and that was 61%. So we're currently looking at a control subset to see if this is a really specific distinction, but it kind of helps us start to speculate where are these vacuoles coming from. We don't know. Here is a study from 1991 by Graver, where he reported this so-called bubble cells, which are renal tube epithelial cells that have this characteristic vacuolization that really not very different than the aspect of the vacuole of the cast that we saw. And we have actually encountered cases where in the sediment, we find this renal tube epithelial cell cast, and some of the epithelial cells do present with large vacuoles, or sometimes the epithelial cells in isolation have vacuoles. So we speculate that maybe some of those vacuolar casts where our renal tube epithelial cell casts that have degenerated, and the only thing that we have left are those vacuoles. But we don't know. I mean, it could be podocytes that are vacuolized. It's still unknown at this point. But it is clear that they correlate with heavy proteinuria. And for that reason, it's important that when you find these casts, you don't confuse them with something else. First of all, lipid cast. Lipid cast here on the top, a bright field microscopy under polarized light, you can see this nice multi-cross sign of the lipids, which is coming from the LDL cholesterol. In a vacuolar cast, there's no polarization. So we don't know what the content of vacuoles is, but it doesn't appear to be LDL cholesterol, probably some just aqueous material. And now you may see what's the difference. Both are seen in proteinuria. Where a lipid cast, can be found in, for instance, a patient with minimal change disease with a zero creatinine of 0.6 and 20 grams of proteinuria. So it doesn't really tell you anything about the degree of renal dysfunction, whereas bipolar casts appear to be more in the advanced disease. So I think it's a little bit different. And also important not to be confused with red blood cell casts. You can see in this top image a red blood cell cast and a bipolar cast on the bottom image, that if you don't pay careful attention, you may confuse. It's different sizes, different shapes of the bipolar cast. But if you find an RBC cast, you may be itching to search for a GN and perform even a kidney biopsy. Whereas a bipolar cast may tell you that maybe this patient is probably going to progress and not much to be done at that time. All right, so in summary, muddy brown granular casts are pathognomonic of ATI. We show you that data today and associated with severity of ATN. Waxy casts could be seen either in CKD or AKI and associated with severity of injury, but the origin of them could be either tubular or glomerular. Renal tubular epithelial cell casts are common in ATI in patients with proteinuria, and they're common in patients with elevated serum bilirubin. Superfluxes and crystals could be a potential culprit for AKI. That requires further confirmation, but it's important to recognize them. Acanthocytes, better detected by phase contrast or dark field, or the use of Sternhardt-Malden stain, and their indication of a glomerular nephritis or a glomerular disease. Renal blood cell casts, you're finding in GNs and rarely in AIN. WBC casts are more common in glomerulonephritis than in acute interstitial nephritis. And finally, bipolar casts are an indication of advanced proteinuric glomerulopathies. So I have a couple more slides to finish because the question is, I try to convince you today that uromicroscopy is helpful, but it's not uniformly adopted despite its clinical utility. And why is that? Is there anything we can do about it? So some may argue, well, I'm busy, I got no time, nobody pays for it, I don't have a good microscope, I'm not gonna do it. That's a common answer. But what if you were to order to the lab and the lab would be reliable and provide you some information? Maybe that would change things and people would use the information. So that's what led us to the EuroCap project that it's ongoing. I'll show you a little bit of what we're doing there. Another reason is that you're just not confident of knowing what to do with what you see in a microscope. Your proficiency is not there. You're not expert. You're just not sure you can do something if you're not well trained. So for that, we're using a couple of other things. The Eurospin is a project using AI. I'll show you a little bit of that. EuroSETI project and the EuroSlide. Let me show you a little bit of those things. So here's the EuroCap project. This is led by Mike Janik, a PhD scientist at the College of Charleston. I mentioned to you a little bit earlier. And in his project, essentially, we were collecting sediments like the one in the image with abundant muddy brown granular casts. And these pellets undergo a process of enrichment by differential filtration and low-speed centrifugation, and we kept these pellets very enriched, very pure with cast, and we sent him to his lab for mass spectrometry analysis using nanology tandem MS. And we have some control sediments of specimens without muddy brown. So you can see here in brown the pellets with muddy brown cast. We also sent him pellets with white blood cells, with squamous epithelial cells or RBCs, but no cast as a control pellet. And you can see here in this Venn diagram the distribution of proteins. We found about 2,000 plus proteins in the sediments with muddy brown granular cast and a number of other proteins in the other controls, as you can see here. But we wanted to see if we find a protein that is specific for muddy brown granular cast, sort of an MBGC biomarker. You can see in this volcano plot here showing to the left proteins that were less abundant in muddy brown cast, to the right more abundant, and then the logarithmic value of the specificity And here in this right column are the proteins that were exclusive to muddy brown cast. 43 proteins were identified. And here's one of them, adrenodoxin, is a mitochondrial protein expressed in proximal tubules. We found it in all 8 of the 12 cases of muddy brown cast and 0 of the controls or in the supernatant. So we think this is a potential candidate for a muddy brown cast biomarker. The other project is the Eurospin project. So this is led by Josian Flores Santiago, former fellow at Oxford, who is very smart, way smarter than me in terms of bioinformatics. And he has developed this program where he trained a model providing images in our archives and training this program how to read acanthocytes. So here are some of the output. So the program can actually circle what the program thinks is an acanthocyte and provide you percentage of probability, or they can essentially color the acanthocytes for you. So if you see a red color, the AI program is telling you that that's an acanthocyte. So this is work in progress, but this is sort of what we will envision is to develop an app that you can pull on your phone, and so the AI does the work for you. What about the EuroSteady project? This is expanding the use of microscopy. I mentioned some of the limitations is lack of expertise, but what if you are able to save the sediment and allow somebody with more experience to come later or the next day to look at a urine? So for this project, actually, put here this is a proud dad moment. This is my daughter. She presented this work at Kidney Week last year, Serenella. And essentially, we collected urine, and then we looked at the urine, took images, and we left samples at room temperature or at 4 degrees, and we look at urine and acquire images 1 day, 2 days, and 7 days later. And here are some of the examples of the things that we look for: granular cast, acanthocytes, waxy cast. Bottom line here is that you can see this example of granular cast, it doesn't really change much. You can keep the urine up to a week, actually up to a month in some cases, and you can still find. So this notion that if you don't look at the urine within 2 hours, that is all lost and we have to collect a new specimen. That doesn't apply to sediments with bacteria because that would change the pH and mess things around. But outside of that situation, you can actually keep the urine. This is an example of an RBC cast that we found 1 month post-collection in a pellet kept at room temperature. So it's really easy to keep. And finally, the Euroslide preservation. So one of the limitations about training in microscopy is that we learn by opening books or looking at images online, right? But the idea is that sometimes we need to find the cast ourselves. And for that, you have to have the slide and learn and get a proficiency by looking at a slide. And the slides that we use for practice, they get evaporation and bubbles, and they don't last more than 20 minutes. So can you actually develop this type of teaching tool like pathologists do? And so we're working with Jay Seltzer using formalin and glycerol and this product called Cover Seal to seal the cover slip. We've been able to we have this box now that I can carry around to teach key examples of calcium phosphate crystal, how about 21 days later you can still see even the waxy cast. So now you can have this cast for teaching purposes. So that we're hoping that we establish this as a technique educational tool. So that's all I have today. Microscopic examination. I hope I was able to convince you that it's valuable and can help you identify different forms of kidney disease. And thank you very much.
Thank you. That was really wonderful. Your pictures are fantastic, as always. So if people have questions, please unmute yourself. Let me stop sharing. Unmute yourself and ask. And we have to get JC out because he's got a flight to catch. But a quick question is, how do your pictures look so good?
So I have 2 ways to capture images. You can have just an iPhone. You have your good iPhones, they have excellent cameras. They sell adapters where you can mount the adapter onto the eyepiece of the microscope. You can actually acquire images with your iPhone. You also can have a standard microscope with a camera, professional camera attached to it and generate images, but that's not necessarily required, but you can do that too. And it's also important that you have to kind of get used to be comfortable learning how to use a microscope. I have visited places where the adjustment is incorrect, there's no calibrated well, the stage is too high or too down, and or there's not, you have to, for instance, you have the condenser that determines if you're going to use bright field, dark field, or phase contrast. It has to be aligned with the objectives. If they are not aligned correctly, then you don't get a quality image. So it's a lot of first setting up your microscope correctly. So I would encourage you to get a technician to come and make the adjustments. Once you have a good microscope, you can use an iPhone and get high quality images and spend a good amount of time.
Yes.
I think it's all of us have taken board examinations where we get an image of a cast and they ask us, what is this? And the quality and the resolution is not optimal. So makes a big difference. Yeah.
And stains.
Stains. So the most essential stain is the Sternheimer-Malvin stain. The brand names are Kova stain, Clay Adams, or SETI stain. You can Google and find online stores. They'll sell it for $140. Okay. It's not very expensive. There's $240 that comes with 3 bottles, and it can last several months. You take once you centrifuge the urine, you dump the supernatant, and then you aliquot some of the pellet, prepare one slide without a stain. When you prepare your first slide, you take a little bit of a drop into the pellet to prepare the second slide. Important not to put a big giant drop because that will oversaturate the pellet. But we do that routinely. Every urine sediment is examined with or without stain. I think that it's extremely helpful in patients with glomerulonephritis. Identifying RBC CAS, WBC CAS without stain is way more difficult. So you're doing a disservice to yourself if you try to do it without stain. It has been an eye-opener, really a game changer.
Using this.
Yeah, it's way better.
I think we do have a phase contrast is what I learned in our hospital as well as the clinic. So, but as you said, you have to learn how to use it. I haven't, so I didn't even know we had a phase contrast microscope. You do microscopy?
I do. I don't do as much as I used to. I mean, so when I was training as a fellow in Toronto, if you presented a case to your staff without having done the microscopy, you would be in big trouble. And it was almost considered part of the physical exam. Yeah. And unfortunately, I think it has almost gone the way of the physical exam in the sense that a lot of people just aren't doing it and get out of the habit, and then aren't as confident in their skills because of that kind of atrophy. So I thought that was, your presentation was fascinating, and really I think you're on the right track. I think the machine learning and that is ultimately what's going to bring this back into the larger nephrology community, because it is a bit of a lost art.
Yeah, no, absolutely, and I think I've shared with you, Swab, before that it's anybody can get the skill. I have learned most of what I know about microscopy way after I finished my fellowship. I didn't go through systematic training on this, and I just kind of acquired a skill and continue to learn to do it better. And it's like you say, I see it the same way as you describe it, as an extension to your physical examination. And a lot of the naysayers who go against microscopy are not fully proficient. So if you don't have full ability to extract the information, of course you're going to see it as irrelevant or not very helpful. But it's really informative if you are able to do it properly and get all the information from it.
And you have to do it often to get better at it.
Yes, yeah. I would encourage you to get somebody as a champion within your team to kind of leads it, gets the setup, starts doing it, and I'm sure somebody's going to enjoy doing it. It's really, I really enjoy doing it. I enjoy the photography, and it's a little extra add-on to it, but it's really helpful clinically.
Peter's got a question.
Oh, Peter, you had a question.
Mostly a comment. Swap, I hope you recorded this because this is one that you fellows should look at / we should look at. Secondly, nobody ever gave us a lesson with the new microscope we got a little while ago, so I think most of us don't know how to use it, and I'm not sure if somebody figures it out, they should give us all a lesson. And we should get some stains and get back to doing this. And then if you're at the Civic where half of the AKI happens, nobody knows how to find a microscope at that campus.
Todd, maybe you know something more.
Mike Harris can prepare this.
Yes, so
Exactly. I do way more this.
David,
Mike Harris loves microscopy. He used to be a
David definitely knows how to use the microscope, as do I. And we definitely have phase contrast and bright field on it. We don't have stains, but it is an excellent microscope, and I'm happy to give people a tour when you're in the pit, or we can do a formal tour.
Do you have polarized light capabilities on that scope as well?
Good question. I'm not next to it right now. I think so, but I can't say for sure.
Yeah, most scopes have a little cassette where you can just get the lens on top, and you put another polarizing lens on the bottom. So it really doesn't require a sort of expensive investment.
Yeah, it would be great you said that there's like an iPhone holder that sits on the lens piece. I think that would be a really nice investment, so that, if people are looking at objects, they're not sure what they are, they could snap a photo and they could be circulated for kind of consensus. And I will say that famous textbook by the Italian sister, I do have in my office. I don't want to leave it next to the microscope because I fear it will walk away. But if anyone ever wants to try and compare images to photos in a textbook, I do have a urine microscopy textbook in my office.
Fantastic. So I think we have you have set the ball rolling for us to do this. And yes, the talk has been recorded, and I would encourage everyone to look at it. Thanks again, JC, for this visit and for your wonderful talks.
Thank you very much. Yes.